Okay, good afternoon, everybody. It's my pleasure to be here in this first webinar of iWIN. Thank you very much for inviting me. And my name is Lluís Blanch. I am intensivist and nowadays I am the director of research and innovation in my hospital. So my talk today will be a little bit opportunities for innovation, and I will do some examples that we did in my institution. So this is my conflict of interest for this. I am inventor of a US patent, a system to detect, to monitor parameters from medical devices, and I am also founder of this startup of my institution. I would like to start with this first slide showing that what will be, the hospital of the future, not only critical care, the hospital of the future. And as you will see here, it's plenty of new jobs, initiatives, disciplines that will configure that hospital. And this is fully in agreement exactly of the hospital that we need after, in that case, the COVID pandemic. This is going to change many, many things. So if we see that the future is big data, sensors, augmented virtual reality, 3D, additive manufacturing, everything in the cloud, new disciplines, Internet of Things, system integrations, I will specifically comment on those three. System integrations to deal with these pandemics, cloud computing, and also additive manufacturing. Having said that, I use this classical picture to see what we are facing. Now we had still in some countries the first wave with all the problems and deaths. Then that will be a little bit the post-ICU recovery. Now we faces new problems. Then the third wave will be what happened with our, in that case, patients that we care with chronic conditions and all people. And in the fourth wave, will be very important, which how we will face the problems of these patients, how we will face hospital organizations, the burnout of the people, and also the economic injury of that. This is very interesting thinking of these people saying that the 10 things I wish I had known some months ago. So, of course, we know too little about personal protective equipment and ICU beds, and this is a challenging for the future. Too much about emails and communications and many non-essential information related with COVID-19, evolving insights related with the disease. This is totally a new disease, and in particular, I will speak about mechanical ventilation and then post-ICU care. Post-ICU care, seeing what will be ICU in the future. And probably we will move from ICU to the totally monitored hospital. This is some data. This is my region, Catalonia. Catalonia, 7.5 million people. And this is patients admitted for COVID and patients of other processes. We completely changed this population. This is a major challenge. And then just a few in non-invasive mechanical ventilation, and suddenly in early May we had this peaking on patients, in that case on invasive mechanical ventilation, together with this peaking in patients, in that case in the ICU. So this is a big challenge because we changed the category of the patient, and also we increased dramatically the number of patients up to a point of almost run out of ventilators. Talking about what we face in my institution, we face problems of monitoring. And this is very well described here, since these patients are isolated. Not quite often nurses and physicians can get in. Those guys just move outside of the room, this monitorization, in that case of the mechanical ventilation. They said that having this, you can see these cables here going through the door. The patient is isolated and they can control a little bit more, the mechanical ventilation, to adjust settings and to ensure lung protective ventilation and so on. So monitoring control of that patient is a problem. I participate in the past in this layer of controlling information coming from departmentals of ICU. In that case, this came, from centricity, but can come from any other, which is a layer that allows a minimum data sets, quality metrics in order to get information. In the time where we need to know what's going on during the pandemic and really to examine what has been, happened during the pandemic, this kind of systems, of monitoring systems to get all the data, it's important. We went a step further. Since we developed this suite of connectivity or platform of connectivity, which is agnostic, it connects any medical device around the patient, monitor, ventilator, or whatsoever. Using that during the pandemic, what we had is some kind of remote monitoring. In any place, we built another ICU, not only in one day hospitals, but in new buildings that we build an ICU. We build new monitoring. Of course, we can get, some data, store some kind of information thereafter, and being all this connected to the hospital information systems. This is the ICU that we built in my institution. This is the 5th ICU. We had the 2 normal ICUs, then another 2 that we built, and then we built that ICU because we ran out of beds, we ran out of, in that case, monitors and ventilators, and we construct that. And for monitoring these patients here, this is an open ICU, we created these big screens connected, in that case, with this connectivity platform. And then we had all this monitoring here, and all this goes to the hospital information system. So, and also we have habilitated some kind of communication of this information system at home. This is personal computer of one of the professionals in the ICU that can see not only, EKG, hemodynamics, mechanical ventilator waveforms, and everything at home. And we did that, in that case, in 10 days. Why that? During a pandemic, innovation, if the hospitals are used to do innovation, what they do is they are really fast when they need to use all data skills in order, to foster patients during this pandemic time. So now just a word on mechanical ventilators. We were really worried because up to a point to do not have any type of ventilator to ventilate the patients. And here you have a graph of total mechanical ventilators in the Catalan hospitals, as a function of the occupied ventilators. And also we had some number, in general, of ventilators. But despite of that, suddenly with a team of different engineers and different physicians, pneumologists, ICU physicians, and so, we try to create a very simple ventilator in order, if we get the point where the green overpasses the blue, then this type of machines, which is just machines, is a volume control, nothing else machine, can support patients. This is exactly what we did in that case in 12 days together with some, technology center. This simulates a hand that compresses an emboot. There are sensors here, in that case for flow, for pressure. There are alarms also for pressure. And now you will see how this go, this is in a patient. This is my team and myself in the ICU. Here is the patient and the ventilator. And here is an example. This patient is not paralyzed, he's experimenting a kind of reverse triggering, not double cycling. That's why, it tolerates this kind of ventilation. So, but this is a situation only if we run out, any other ventilator which has been evaluated, which has been, in that case, pass all the processes in that case of evaluation, then we can use this type of machine. So we were prepared for that. Fortunately, we don't need, the use of that ventilators. And again, if an institution, it's is used to do innovation, we discovered that in that pandemic, we ran out of simple things. Simple things means that flow meters, means, connectors, means wires, means, dishevables, all kind of different pieces. We have in my institution a 3D lab for prosthetic devices in trauma, in orthopedics. So we put that 3D lab completely to work, to provide this type of pieces that we run out. And then not only we provide, this type of 3D additive manufacturing pieces for my institution, but also, I mean, for other 33 health centers. So we produce almost 20,000 items that with together 60 companies and 10 technological centers in order to distribute this. And this is a graph, this is in blue, the pandemic, you will see here. I mean, in that case, detected cases, here the related deaths in blue, and this in gray and the shadow is the web visits of what we were doing, and in red, when we start to distributing all these pieces up to a point of the 20,000. That's why if you in your institution used to have an organization that fosters innovation, that tells what innovation means together with investigation, in that case, we can very easily develop, I mean, all kinds of solutions in this type of crisis and pandemics. And that's it of my talk. And I would like to end with this slide. That was published in JAMA almost 10 years ago. But she's a lady, young lady. She's very happy because, I mean, she succeeded in that case, sepsis. She survived a sepsis, and the family is also very happy. And now we are facing a technological world. We are facing a technological hospital. And we need to be really, really, really cautious and to care, because this young lady see the physician, you know, as just, you know, tac, on the computer, playing on the computer without, I mean, seeing probably him or her, you know, as an humanized person, you know, that is at the bedside. So we are going to a complete technological and monitored hospital, but we must take care of all the humanities in the patients before, during, and after the pandemics, and maybe this will not come back again, but if it comes back, we must be with lots of humanity. So thank you very much for your attention.